Welcome to today's webinar, Why Choose BOSA? Utilizing the Bruder Ocular Surface Analyzer to drive decision-making for you and your patients. We appreciate you taking the time to join us. Our goal today is to show how the BOSA's diagnostic images and data can be used not only to confirm your clinical findings, but also to educate patients, strengthen compliance, and support treatment conversion in a clear visual way. We're very fortunate to have with us one of the most respected voices in dry eye and anterior segment care. It's my pleasure to introduce our featured presenter, Dr. Selina McGee, Chief Optometrist and Visionary Founder at Bespoke Vision in Edmond, Oklahoma. Dr. McGee is board certified with a clinical focus in comprehensive eye care, anterior segment disease, including dry eye and specialty and custom contact lenses. After earning her optometric degree, she worked at the Dean McGee Eye Institute and went on to practice ownership, where she expanded services for advanced dry eye, specialty lens care, and later added ocular aesthetic rejuvenation. She is a fellow of the American Academy of Optometry, former president of the Oklahoma Association of Optometric Physicians, and past president of the Intrepid Eye Society, an international speaker on dry eye disease, and the 2021 Journal Record Healthcare Hero. On behalf of M&S Technologies, Bruder Healthcare, and Hilco Vision, welcome Dr. Selina McGee.
Perfect. Thanks, Monique. Thanks, everybody, for tuning in. We're going to have some fun in the next 30 minutes. And I have some time left over so that you guys can ask questions kind of as we go too. I've had this technology for about a year now, and I've had prior technology to this. And we do, a lot of things in our clinic, whether it is all the way from Lacrophil to IPL to radio frequency, and then kind of everything in between, lid therapy, all the things. And so when I look at what I'm going to make an investment in and how do I inform my clinical decision making, I heavily rely on tools. And if we don't know what the information is telling us, it's hard to do that. So that's what my goal is for you guys tonight, is to see this technology, and then how do I incorporate that into my clinic flow? How do we utilize this type of technology to help us, not hold us back? And how do we do this in an efficient manner? So that's really what we're going to talk about. And whether you are in a dry eye center of excellence and you have every new tool, or you are just starting out on your dry eye journey and starting to really enhance what you're doing, this technology can help you at any step or any juncture of where you are in your dry eye career. I still see a lot of primary eye care patients, and so I am my biggest referral still to my dry eye center. I do get, patients that come from OD offices, MD offices, self-referral, that they found me on some sort of, website or Google search forum for dry eye. But no matter what your clinical background and where you have it, there's a role for this. So we're going to kind of explore that and what that looks like. So when we think about, how do we treat dry eye? First, we have to talk about how do we diagnose dry eye. And what I find, and especially with the most recent publication of TFOS DUES 3, there's a great section in there that looks at when it's not dry eye. And so I like this slide because we talk about why is dry eye disease underdiagnosed and undertreated. It can also be overdiagnosed when we're managing the wrong disease state. And so what I'm going to show you with BOSA is how to not underdiagnose and also to correctly diagnose. Because so many of our patients will normalize their symptoms. They think this is just how they have to live their life. And you guys all see patients exactly like that. And when I tell patients that, you can literally see their frustration and their anxiety slow down, and their shoulders come off of their ears, like, oh, wait, you can help me. I don't have to live my life like this for the rest of my life. I had no idea. And so there's so much opportunity here because it is underappreciated, underdiagnosed. And on the doctor's side, frustrating when you're, not even managing the correct disease. And there is a big discordance between signs and symptoms. I'm a huge proponent of utilizing some type of questionnaire. We personally use a speed questionnaire on every single patient. If it's 6 or greater, that is significant. And we automatically are doing more point of care testing, but it really sets the stage and allows us to uncover symptoms that patients won't always tell us. And then the way that we utilize this technology is we use it on pretty much every single patient. So it's in our wellness exam, which incorporates the BOSA plus our wide field imaging of the retina and a 9x9 cube of their macula OCT. And so this is part of what we do, and our capture rate's about 96%. So essentially, pretty much every patient that walks in the door gets a few of these tests. And once we get diagnosed with dry eye disease, we take a little deeper dive. But just the sheer amount of patients that sit in my clinic and look at, wow, I've never seen a screen that looks like that. I've never seen testing like this. I've never experienced this. I am a high touch, high technology practice. And so you can really create some wow factors, and you can at the same time educate, you can reinforce why you're doing procedures, you can diagnose with this, you can treat and manage with this. And so having this kind of technology can really kind of reaffirm and also confirm what you're already doing in the clinic, and it's just going to enhance everything that you're already doing. So we have a lot of different tools built into one platform. You know, none of us want to pay extra for more real estate. So the more things that I can have in one device that doesn't take up a big footprint is super essential. And I don't want big bottlenecks in my ancillary testing room. And so this allows me to have a lot of great technology in one piece, whether it's automyography that we're looking at and we're imaging and talking about structure, whether we're looking at interferometry and how much oil do I actually have mixed into the tears. And then that non-invasive tear breakup time is super essential to know and inform what I'm doing next steps. Am I going to add lacrophil? Am I going to recommend a procedure? Do we have the wrong disease diagnosed? Do I have increased tear meniscus height? And it's actually because of a drainage problem that the patient's complaining of watering. So there's so many ways that we're going to look at this, and then looking and reminding patients about how they blink. And it's not just the amount of blinks, but the quality of the blink. And when they can see their own imaging and they can see what you and I are talking about, those images are worth 1,000 words, like we've all shared. You know, you can also add, we have a ton of patients with Demodex blepharitis. So that external photography is lovely to have when you're talking to a patient about collarettes and the fact they have Demodex mites living, you know, inside that hair follicle. And so those images are really helpful. You know, you can bill for that, you know, and we can dig into more redness and, you know, have some really sophisticated conversations there. So this technology gives you a wealth of information about what's happening on the ocular surface. And so hence the name Ocular Surface Analyzer. It's going to help us do that. When we're behind the microscope, you know, I do a lot of vital dye. I'm still pushing on glands for functionality, but this just enhances everything that I'm already doing during those routine exams. So the other piece I like about this is so much of dry eye can be subjective. We're subjectively asking the patient to measure their symptoms in an objective way by doing a validated questionnaire. But when we have objective results like this, it helps drive decision making, and it makes your protocols. And if you don't have protocols, it allows you to set protocols based on what you're seeing. And you can really start to customize and create some really nice ways to manage your patients, especially if you have more than one doctor in your practice, right? I have 3 doctors that work in my practice. And so I want the patient experience to be the same across the board. They might experience my personality differently, but the way that I manage the patient shouldn't be different. And so this allows you to get everybody on the same page, okay? Because you've got objective measurements. And so here's just some examples of external photography, pseudomembranes, you know, looking at herpes dendrite. So there's really some nice things. And then of course you see their ocular rosacea patient over there in Demodex blepharitis, which is the most common things that we see. Nice chalazia picture. So I like that this allows for education. when you think about what we spend a lot of our time doing and what we should be doing is strengthening our conversations. I see about 55 patients a day. So I need to make the best use of my time, and I don't want to slow myself down. And so I am not the one gathering all the data. I am the one analyzing and then educating the patient. That is my job, is taking the information, not gathering the information. And so when you have a way like the BOSA to have a technician help you along this journey, or maybe you're at the very beginning of your journey and you are the one still collecting all the data, it's only going to enhance everything you do behind that. So looking at my biography, here's a great example of showing a patient what they have and what they should look like. And when patients walk into my clinic, these are the images that are pulled up. And I'll just, you know what, I'll just show you guys. So I have two 42-inch screens that sit right behind me. And that is what is pulled up in the room. So they already have imaging that they're looking at before I ever walk in. And this is one of the images. And so they will see that and they'll look at it and say, wow, there's a really big gap there. What's happening? They don't even know what they're looking at, but they know that that's not correct. And so it gives us an opportunity to talk about, okay, look, we've already lost glands. We're not going to resurrect them. We can't do anything to make us grow new glands. We need to keep the ones you have. And this is a warning sign because you should look like the picture on the right. And patients understand that. So when you're thinking about conversions and you're educating, this can really help you do that because the patient, again, sees what the problem really is. They're not just taking your word for it. When we look at videos, and these will play in front of the patient. So let me just show you a before and after. So maybe you've had a patient who you did IPL on, and you're on, the last post the fourth treatment, and you say, the patient's like, man, I really invested a lot of time and I don't see much different, doc. So let me show this again because it's powerful. When you can look at the pre-IPL on the left and the post on the right, you can actually see all of those lipids. It's really clear that maybe they don't feel better, but functionally we have better interferometry, and you could never show a patient that, right? So it does give you another way to reinforce and strengthen that conversation when you have that kind of technology, because it's not just you saying that, right? That's objective testing and objective videos of the patient. So I thought those were great images that Andrew gave us on those pre and post. And then let's look at, what about blinking? We talk a lot about this. And when you stare at a screen, your blink rate goes down to 7. But what about the quality of the blinks? So you can educate and show the patient as you're having this conversation, where they fall, and then look at what kind of blink, how many times they blink, and they can see, look at that partial blink, right? And so those are super powerful images to better strengthen, again, what you're already talking about. The videos are worth 1,000 words. And so the other one that I want to show you as a video is looking at non-invasive tear breakup time, which I love because tear breakup time behind the microscope is honestly pretty difficult to do, and it's hard to be consistent with it. And so this allows us to have a conversation about looking at that tear breakup time, and it's done in a non-invasive way, and you can actually see how that imaging goes alongside the patient, and you can see those placebo discs just blur out. So you can imagine and talk to the patient about what you would discuss there. Do you feel like you sit down to read a book, you read a few lines and things start to get blurry? Here's why that's happening. So it just strengthens your why. And again, it gives you these really great ways to help educate along that journey. And then I don't know about you, but if you're seeing as many patients as I am, or even if you're not, our time should be well spent. And when you're looking at reports, or you want to give something to the patient so that they have an understanding, maybe you're in a referral center and you've got other doctors that are referring. Like, this is the kind of technology that you could certainly share with the patient. You could certainly share it with your referring docs. If you want to build that referral, you can show them that you have this technology and you're capable of this. And so these reports are really nice to be able to hand to a patient, and you can customize this. You can decide what you want to put in the report and how you want to do that. So just gives you a lot of good ways to really like strengthen those referral relationships and honestly solidify why the patient came and sat in your chair. So it allows you again to standardize protocols, and you get to utilize this. You get to decide, okay, I want these 3 things on this type of exam, or I want, everything that BOSA has to offer on a dry eye consult. You can customize that, which is nice. And so, on my patients that we're doing the opening screener, it's mybography, it's non-invasive tear breakup time, and we're looking at interferometry versus a dry eye consult. I'm doing pretty much everything. So you can customize that to how you want to do that. And some of these are already built so that you can use a fast way and then a more in-depth way. So key takeaways, this device does a lot, and you can standardize and objectively measure testing in a few minutes. The software is going to help you with education. It's going to help drive your decision making because now you have clinical objective measures to look at. And then you can help educate the patient with imaging, and you can do that through mybography, external photography, interferometry, like all the things. You can make this integrate into your workflow. I mean, I see a lot of patients, and this does not slow me down. It can help you with your conversions because patients actually see what you're talking about, and it can also reinforce that investment that they made with you if you're doing procedures. And then it just gives you this imaging of this wow effect. I can't tell you how many patients are like, I've never had this done. It's really fascinating. And I mean, if you've ever done mybography, they're so funny. Like a lot of people are like, ew, what is that a picture of? Right. And I love it. And then I can really like geek out and nerd out with my patients. And sometimes they appreciate it, sometimes they don't. But at the end of the day, you want to have technology that is going to inform your decision making. It's efficient, that you can put into your workflow, and it's going to help you grow your practice and better manage the patient. You don't ever want to put anything in your clinic that doesn't help you do those things. So educate, certainly grow, and then give patients that wow factor and reconfirm why they chose your practice either today or, along the way and along the journey, depending on what your culture looks like. Again, I am a high touch, high technology practice. This is what patients expect. I've designed it that way on purpose. That is my culture. I believe culture, you either have it by design or default. And this is very intentional, and we have designed it in this way. So I would love to answer questions, and I made sure that we had enough time to do that. And one of the first questions that came in was, are the images acquired by a technician during pretest, or are you taking it like in the exam room by the doctor? I think in most clinics, it is much more advisable to have a technician help you. I really firmly believe that we have to get out of this mindset of we are the data collectors. As you look at what's happening in eye care across the board, we need to take more care of patients. So we have an access problem, and we need to be able to be the data analyzers. And you use this type of technology to augment your own intelligence, and you're going to lean on a technician to help you gather the data. You lean on the technology like BOSA to analyze and give you the right kind and good data. And then you as the doctor are the one that is taking that data, taking that analyzation, and then making informed decisions on how to best manage the patient. So I think that it should be the technician during pretest. And it just kind of depends on what your clinic flow looks like. Some docs, want just mybography, and you could certainly do that with a technician. And then maybe as you are talking about procedures in the room, you use the fast wizard and you don't do all of the things because it's really quick. So it just depends on your clinic flow, but here's the beauty of it. You can customize it and you get to be the doctor and choose how you want to incorporate this. And there's multiple ways to do that. You just heard my version, but you can make it your version too. Another question, I'm researching for instruments and equipment for a group practice startup. What do I suggest as an alternative to doing heat and expression? So the interesting thing is TearCare just got approval for 2 Medicare providers. So I'm in Oklahoma and that is Novitas. That's our Medicare carrier. TearCare, which is made by Sight Science, is one of those that actually gets reimbursed from Medicare and quite a few commercial insurances as well. So I would reach out to Sight Science because we're starting to see that, and it's specific, the code they have is specific to them. So if you're looking for heat and expression and you want something that insurance helps us with, that's certainly one you can explore. I do utilize IPL and I have packages where we're doing IPL along with radio frequency to tighten, and then we're doing heat and expression with TearCare at the end. Full disclosure, I am a consultant for Sight Science, but there's lots of ways to do that. But I would encourage you to look at that because the front investment is low and the activators, it's going to depend on insurance because insurance is basing it on how much those activators cost. So explore that as you move forward. And then let's see, another question. What's the difference between the BOSA and the Antares? So I actually had an Antares before I had the BOSA. I got it whenever I added my M22 like 8 or 9, 10 years ago, whenever that was. When I compare this to my Antares, because I had the exact same technology that you had, this one does so many more things. I really use my Antares as a mybographer. It did have a corneal topographer, but I never really loved it. And so when you look at BOSA, it's way more. You're getting interferometry, you're getting non-invasive tear breakup time, you're getting that blink analysis. So a lot of those videos that I showed, the Antares never did. Of course, your external photography, it was only black and white. You know, if you want to add fluorescein staining photography, pupillometry, if you want to add in your speed questionnaire, like there's so many things. It does a lot more than my Antares did. So it's funny that that's the exact same technology I had as well. So this only enhanced it. And my patients that saw the Antares over the last, 8 or 10 years, when they saw this one, they're like, "Ooh, you got a new piece of equipment, Dr. McGee." Like they clearly knew that there was a big difference because it had a lot more imagery and a lot more videos that we were educating with. Just food for thought. This one does a lot more. What's the one piece of equipment that I would add that gives the most information for MGD dry eye evaluation outside of tear osmolarity MMP9? I love non-invasive tear breakup time. I like the interferometry and the tear meniscus height. So those 3 things, honestly, if BOSA did just those 3 things, I would still get it, but it does a wealth of other ones. When I look at that, and your tear osmolarity is going to get, sometimes reimbursed. MMP9, I can hardly ever get reimbursed, which is really frustrating. But for this purpose in this example, even if I just had those things, tear meniscus height, non-invasive tear breakup time, and interferometry, it would be worth this investment because those tools really help drive my clinical decision making. And you've seen and heard that it does a lot more than that. I do think if you're on this webinar, you're obviously invested in dry eye already at some level. And again, whether you're at the beginning of that career or like me, I've been doing, heavy dry eye since about 2006. There's a place for this and you can lean into this and you can also really grow with this. And I think that's always important because sometimes you can invest in technology and you can outgrow it. But with this one, because you have so many applications, this is something that you can utilize, a few of the elements and really start to build and get your confidence and figure out that flow. And then you can continue to expand on it as you add more things to your dry eye clinic. You're not going to outgrow this. And so that's another thing that I always consider when I look at, what I'm going to invest in and where's the ROI, how long is it going to take me to pay this off? What kind of procedures, what kind of things am I doing to help with the ROI on this? And so that's something to consider too. And the pricing on this, allows me to definitely into that.
Does it take more than one technician
for mybography? Some instruments are challenging.
It doesn't take more. And just to clarify also, I typically only image the lower glands. Now, when I have a patient that has no lower glands left, or I do want to image the upper ones, I would say that you should look at something called the Bruder, which is a little instrument that you can use one-handed to flip that upper lid. And that alone will do that. But I image all lower glands always. That only takes one technician. And if you want to image uppers, I would utilize that small tool. It's not super expensive, called the MyVerter, to help you with those upper lids if that's where you want to image as well. Again, rarely do I do that, but only one technician. It's a great question. You don't want to add something that's really going to wreck your efficiency and require more than one person to do this. And also, I have 4 technicians and they are all equally trained on this. And so, sometimes you'll have, a really crackerjack technician and you're like, oh, she's the only one or he's the only one that can do this because the technology is a little finicky. And I have 4 technicians that are at different levels that have been with me for different amounts of time, and they are all able to utilize this technology. It's a great question.
And the benefit of the BOSA is that you're not reaching around the big head of a topographer. It's much easier because it's designed just for dry eye. It's a very small head. So you can reach around and do lowers very easily and even do the uppers.
Yeah, and it's nice, like just to her point, and especially if you're a technician, like doing this all day, every day, and you're like, you don't want to be in a big clunky space. And I don't want clunky equipment in that ancillary test room either. And so the fact that this has got a small footprint, super important.
There's another question. How long does it take for all the tests per eye versus screening with a few tests?
Monique, answer that one for me.
We have 2 different versions. The Fast Wizard is 15 seconds an eye plus mybography. And with the 15 seconds an eye, you're getting interferometry, blink, tear meniscus height, and non-invasive tear breakup time. That's the Fast Wizard. When you go to comprehensive, which might only take another 45 seconds, the difference is you're getting a more comprehensive blink evaluation, and you're able to catch those missed blinks. So on the Fast Wizard, you are telling the patient when to blink. When you use the more comprehensive, you never tell them you are looking at their blink. We tell them we're looking at the lipid layer. We ask them to blink and explain that we're measuring the lipids between the blinks. It's just a little bit longer, but worth it, especially when you can capture incomplete blink, because that really resonates with patients.
Well, and that Fast Wizard, to your point, 15 seconds per eye, I would spend longer behind the microscope doing that per eye for all of what we get out of that.
BOSA versus keratograph.
In my opinion, I think that the keratograph is a very well done instrument. And, the crystal reports that Crystal Breimer put into that device are very informative. From a price point and an investment side of things, I think the BOSA is the ROI on it beats it every day. So this is technology that, in my opinion, equals the 5M, which has, kind of been a standard for a long time. But for the price point and the team that you get with Bruder, that's where the ocular keratograph can't compete. Well, Monique, thanks for having me. Thank you guys for joining in. Ask any questions. She's got my contact info. So if you're anywhere that you can get your hands on this and try it, of course. But if you're at that level, again, whether you're at the beginning or wherever you are in your dry eye journey and what you're bringing into patients, this is going to level you up, to say the least. So thanks again for hanging out with us for 30 minutes tonight. And I look forward to seeing everybody at a next meeting or on our next webinar.